We are your hosts, Nikki Shore and Jesse Swain, and you are listening to the American Journal of Infection Control podcast, Science into Practice, brought to you by the Association for Professionals in Infection Control and Epidemiology to highlight work published in our peer-reviewed journal, ACHIC.
Join us as we speak to those in the field of infection prevention and control, like us, as well as other experts, to learn about some of the latest research in the field and how it can be put into practice. We hope you will listen in, learn something new, and apply this information to your work. If you are not a researcher already, we hope this podcast will get you thinking about areas where you can carry out your own research. Hey, Nikki, how are you?
I'm good, Jess. How are you doing?
Doing pretty splendiferous. Spring
I
is
like that
springing.
word. I like that word. I have to tell you, you don't know this, but we used the word, we as in me and my husband, used the word splendiferous in our wedding invitations.
Oh, I love that. That's fantastic.
Yeah.
I'm glad I'm not the only one. So,
Wait, you used it in your wedding invitation?
no, I mean, I'm glad I'm not the only one that uses that word.
Yeah. It's a cool word.
It's fancy.
We'll use it more often.
So, there's a lot of infection prevention in the news these days, huh?
Yeah, I guess there is. Yeah, there is a lot of interesting information going on out there, and I'm assuming that you're talking about Candida auris. But speaking of splendiferous and my husband, I sent him, off the topic of Candida auris, I sent him an interesting article the other day, and it says that men's beards have more germs than dogs. Huh. Yeah,
Ew.
he said, I know, it was weird. And he said, well, of course, there's no dogs in my beard. Oh, what a splendiferous joke.
Yes,
Sorry.
as always.
Sorry, guys. But we do know that hospital-acquired infections are always going to be newsworthy. So you know what? We'll just roll right into it. I'm going to introduce our two guests who will be talking to us today about their research paper, Impact of Patient Safety Climate on Infection Prevention Practices and Healthcare Worker and Patient Outcomes. And the paper starts with a shocking statistic. 99,000 patients will die annually of a hospital-acquired infection. So Drs. Amanda Hessels and Dr. Elaine Larson are going to be talking to us today about how a culture of safety can impact those numbers. So Dr. Amanda Hessels is an assistant professor at Columbia University School of Nursing and a nurse scientist at Hackensack Meridian Health. With an exceptional nursing career spanning 25 years, Dr. Hessels is respected as a researcher, educator, and clinician. By bridging academia in the healthcare setting, she is distinctly capable of identifying and addressing real-world problems, and through leadership, innovation, and action, she is creating a legacy that includes both scientific acumen and sensitivity to clinical operations and practice. The signature of her substantive, sustained, and lasting impact on nursing and health is a body of research at the intersection of patient safety and occupational health. By describing and quantifying the role of human factors, organizational and clinical practice predictors of healthcare associated infections and occupational health injuries, her work has led to practice and policy change regionally, nationally, and internationally. Advancing these scientific breakthroughs and with current federal funding, she is developing interventions to improve adherence to infection prevention practices. Dr. Hessels' scholarly contributions are vast and include numerous editorial board positions nationally and internationally, leadership roles in national organizations such as the Association for Professionals in Infection Control and Epidemiology, and selected invitations and appointments to national scientific panels and committees. Dr. Hessels earned her BSN from University of Rochester, MSN and MPH degrees from the City University of New York, Hunter College, and PH degree in nursing from Rutgers University College of Nursing. She completed a postdoctoral research fellowship at Columbia University School of Nursing, one of our many busy guests that we have on. Now, Dr. Elaine Larson is Professor Emerita, School of Nursing and Department of Epidemiology, Columbia University, and Senior Scholar in Residence, New York Academy of Medicine. She is a fellow in the National Academy of Medicine, Society for Healthcare Epidemiologists of America, also known as SHEA, Association of Professionals in Infection Control and Epidemiology, American Academy of Nursing, and the Infectious Diseases Society of America. She was editor of the American Journal of Infection Control for 25 years, has published more than 450 journal articles, 4 books, and a number of book chapters. Elaine is currently the president of the Certification Board for Infection Control and chairs institutional review boards for Columbia University in the New York Academy of Medicine. And Jesse, before this, we were talking about how a fellow IP of yours said she wanted to be Elaine Larson, and I can see why.
That's right.
Yeah. So, Drs Hessels and Larson, like I said in the intro, 99,000 patients will die annually of a hospital-acquired infection. So clearly, this is a very important area of infection prevention. So I'd love it if you would kick us off with a little more detail on what prompted the research.
So the reason that we want to examine this, and really this is sort of a midpoint of a program of research, so we could share with you really what led to this in the earlier work in developing the tools a bit later. But the reason is, as we know, and Elaine sure could share this is an unrelenting issue, right? We all have a friend, a family member, a colleague, a loved one who has suffered some harm at the hands and in the settings of providers and systems and organizations who mean well, and organizations that are structured well. And so why is this harm occurring? How could we support healthcare workers to do the right thing, the right way, the right time, all the time for every patient? I think when we think about the humanity of this issue and the long-term impacts of people, what they deal with when they're discharged to home, when they're discharged to long-term care, et cetera, those issues, those HAI numbers, they don't disappear, they persist. And so this is an issue, and at the right setting, if we could intercept between the patient and the provider to see what's happening, what, if any, missed opportunities are occurring to provide the right type of care, the right safe care, that's really what drove us towards this area of research, but specifically looking at things such as, what is the safety climate? As a nurse, I know when I've worked on different units that some units we worked seamlessly together. Some shifts we worked seamlessly together. Other times you would get that note to float to another unit, right? And you'd say, oh gosh, dear, don't float me down to that emergency department. Don't float me down to that unit. They don't work well together. Things are going to happen on that shift tonight. And so we want to examine some of those possible predictors of that climate, how those folks hang together and cluster together to keep themselves and patients safe. Mm-hmm. And with that, Elaine, did you want to add anything to that?
Well, I just wanted to say a couple of things. One is that Amanda has had this passion since I've known her, which is over a decade, and that is because of her experience, her clinical experience. It's clear that there is an impact of the team culture on a lot of outcomes. And many, many years ago, there were some papers published that showed that even morbidity and mortality in intensive care units were significantly related to how well the interdisciplinary team worked together. And when the physicians and the nurses did not work together, patients were more likely to die. So it's very clear that this has been around for a long time. And what we've been lacking is some of the firm data. And one of the things I'm so pleased and happy for Amanda and delighted is that she's publishing some of the first real data to show that there is a link between lots of untoward patient events, particularly infections and the behavior of healthcare personnel. So this is why this paper is so important. It's one of the first that has some good solid data and lots of it to show this kind of a relationship. So kudos to Amanda and to the team. And I'm excited that now the work is really to get this disseminated and figure out what the next interventions are going to be.
Yeah, we are excited to dig in.
Yeah, I agree. This paper is full of data. It was a lot to go through and read and understand. So I was also very impressed. And so to start off, one of the methods that was used for gathering data was a survey on patient safety and standard precautions used to measure healthcare worker perceptions of the patient safety climate. And this included 44 items measuring 12 different dimensions of patient safety climate, which sounds extremely robust for a survey. Can you tell us a little bit more about what some of the items that were measured were and why were they included? What was the importance of having these as part of that survey?
That's a terrific question, Jesse. And I would love to chat with you more over a cup of coffee about all the data that we actually pulled out of this paper to make it more readable. So I hope it's not too dense, but you did pick up on some key points there. So several years ago, when Elaine and I were discussing this, and I was working with another mentor as well, Dr. Robin Gershon, we thought about, as you know, in research, you want to identify tools that exist. It's more challenging to create your own tools. And so scanning the literature and seeing something that was already used, so it was familiar to the end user, meaning the person that I'm going to survey, and familiar to the organization was important. Being freely accessible was also important. And of course, being a reliable and valid tool was important. So I identified a tool which is used in many organizations, some of yours probably as well, the Agency for Healthcare Research and Quality Hospital Survey on Patient Safety Culture. And so that has an extensive, and it's well documented in ARC, extensive body of literature documenting how it's been used. And they come with an explicit survey user's guide, which is also helpful for that. So it measures, again, the perception, good pickup there, Jesse, meaning what the nurse on the unit perceives, how they rate something on what we call a Likert scale. So a 1 to 5, where 1 is they disagree or it's a negative score, and 5 is a high score. What we did, though, is we added, and this was with funding, by the way, from APIC Heroes of Implementation Research Award that I received, which was supported by BD. And so we added additional items. And these include the additional 22 items from Dr. Robin Gershon's tool. And those items, again, are they measure in 2 different sections, the standard precaution practices from the perception of the provider. So that's a self-report measure, again, from never to always. So it's a frequency of event, how often they do something, as well as their perceptions of the environment, how supportive or barriers that may exist in the environment to the provision of that care. And I could keep going on and on, but I want to see if I'm making sense to you at this point.
Yes, absolutely. It definitely makes sense. Yeah.
Great.
Yeah, that was great. Thank you.
And if keep on going on that one if you're interested. But I also wanted to talk. I wanted to bring in the other tool that was used, the standard precautions observation tool. I think that was called STOP. And I know that you had site liaisons working with that tool. So tell us a little more about that one as well.
Oh, sure. That was a fun one. And so we developed this as, under Dr. Larson's tutelage and working with her on this during, again, that same period of 2016 or so when we first developed this. We identified tools that existed, and we all had heard of at that point, or were beginning to hear about the World Health Organization tools and items, right? And so they had developed a tool for hand hygiene. My interest really is about all those things that happen beyond hand hygiene. Hand hygiene is great. Direct contact, we're concerned about that. Indirect contamination is, we're concerned about that too. But there was no tool which existed to capture all of those other issues of items of standard precautions. And those buckets, we know, again, one of the problems that we were addressing is the suboptimal adherence, less than 50% of the time reported in the literature, to all of these items. So what we did, Nikki, to the great question, is we developed this tool, which we term the SPOT, S-P-O-T, Standard Precaution Observation Tool. And in that tool, what we created a user guide and a series of case vignettes from real practice to train our liaisons and for others on using that tool. Of course, prior to using it in this study, we wanted to be sure to conduct what we call psychometric evaluation, and we included content experts, importantly, infection preventionists, health services researchers who had extensive expertise in tool development, and a nurse researcher, because we wanted to assess the face validity of the tool. And then we convened a panel of experts and end users to confirm the extent to which the items that we're measuring are capturing that complete range of standard precautions, right? And so then we moved into field testing to establish what we would term integrated reliability, meaning if Nikki and Jesse, you were both in the same hospital at the same time using this tool, did you agree that you saw a provider go into the patient's room and wash their hands or not, right? And it's amazing when you're actually on site and in that patient's room and with people doing this, you may not see something that your colleague might. Mm-hmm. And that's alarming. That really taps into, I think, really our situational awareness. So again, we want to measure that. So moving into, Nikki, your question about the training of liaisons and observers, right? So I could collect all these data. Elaine can collect all of these data. Somebody else can. But if we're doing it differently or nobody else is, then what's the benefit, right? How is this helping anybody? So really what we wanted to do was sort of train the trainer and have that model of rolling this out, similar to the On the Cusp and other initiatives, where we said, let's engage with nurses with IPs who want to engage in research, and they could actually apply it, right? That's the key, is applying it to your setting and mm-hmm. translating the tools and knowledge to your setting. Mm-hmm. So we recruited these site liaisons and we developed a training modules, and we worked alongside each one of them, each set of them at these various hospitals and across hospitals to make sure we were all on the same page. And then we would debrief to say, wait a minute, I saw this happen. Do I count it as this or do I count it as that? Now, with regards to the actual tool, that is on that actual training tool, we have, it's a dichotomous measure, right? And in that measure, it's just basically yes, no, was something done? And I could tell you, oh my gosh, the stories Elaine and I could share about our heated discussions about using this tool. It was just an ugly mess of an instrument. It was not usable. You couldn't, it was horrific. And we went back and forth. Well, what are we measuring? And well, what do we see? And so again, we limited this to those items that were simply observable and consistently would be standardized across settings and policies. So as an example, we included hand hygiene only before touching a patient, after touching a patient, after contact with the patient environment surrounding. PPE, we included donning gloves, donning and doffing gloves, donning and doffing a gown, and donning a mask. With handling needles and other sharps, we know that there's a number of recommendations put forth by the CDC, but the one that we could most readily and consistently observe was handling that needles and sharps by immediately placing it, the used sharp that is, in the puncture-resistant container. All those other things of recapping, et cetera, I didn't measure those, right? I wanted something that was going to represent that bucket, right? That bucket of standard precaution items of handling sharps and needles. Right. And then similarly for disinfection and contamination of the environment, some of those practices may differ. Who wipes off the telemetry leads, et cetera. It might be an aide, it might be a nurse. Those will differ across your settings. But the one thing that's consistent, regardless of that provider, everybody handling a soiled and contaminated linen should immediately put it in that designated laundry bag. Not on the floor, not on the patient's table, but immediately in that soiled container. So those are the 10 items that we would measure. Again, with the dichotomous, was it indicated? And then check, was it done or was it missed? Was it done or missed? Done or missed? Very simple. right? Not complicated math or arithmetic here.
I think the inter-rater reliability and the simplicity is critical to ensuring that you're getting that really good, reliable, valid data.
Yeah, let me add too that part of the reason it's really important is because hand hygiene, monitoring of hand hygiene has been mandated by the Joint Commission for places that are accredited, but there's been evidence that the observations are not very reliable, they're not very valid, and they differ. So it's really important to have something that staff trust, because what they'll say is, well, the problem is you're just not observing it right. It's not accurate. So it's really important to have an observation tool that people can trust. And that's why it's important to show that it's simple, as you pointed out. And otherwise, people will always, everybody, it's just human nature to say, well, it really wasn't that bad. It was that the observations were not valid.
So sort of speaking to what we were just talking about, the article also mentions that the adherence to standard precautions in general occurs less than 50% of the time, which it seems scary. What do we think some of the underlying causes are for this lack of adherence?
So that is a terrific question, Jessie, and that's the burning question that drives my research. If I knew that, I would be bigger than Bezos, right? richer than Gates. If we could solve that age-old, and that's the nugget of that kernel of knowledge that we seek. We want to understand that, and we all know that you don't want to boil the ocean when you take on a QI project or an IP project, right? You need to find a very discrete question and start somewhere, and that's why. In this study, we began to examine some predictors, and we also included some potential confounders that the literature or empiric evidence would suggest might predict behaviors or outcomes, such as hospital magnet status or nurse staffing, et cetera. So in this study, we thought that perhaps safety climate might capture some of that. And, by safety climate, and you could see in the paper itself, that includes categories, or what we would call dimensions. And each dimension may have 3 to 4 items, right? Because it's 44 items. And so you may have 2 or 3 items which will measure staffing or the non-punitive response. And so we have, additional data which we could examine, which says, hey, which one of these? And if you look down there and you look at that specific table, you'll see that by and large, most of them were correlated with the reported, as we would expect. It's the same survey. So most respondents that reported positively their safety climate also reported positively by self-report that they did the right thing. And so to your question about things that might predict, when we organize this, I kind of put that down in descending order. And you'll see that the most important thing, or the highest rated thing on that scale, is teamwork within units. And so if I were the administrator, the policymaker, if I were that nurse manager on that unit, and I were to say, wow, there's so many categories of things to improve, but how do I possibly do it all? And can I afford to do it all? Where do I begin? I might say, you know what? Why don't you look at these data and or collect your own data on your own unit? But you could look at some of the evidence in the literature, such as published in this paper, and you would see that, okay, teamwork within units, that's something that counts. It was not statistically significant, but people rated that very highly. So then you go down and you say, well, what was statistically significant? And there you'll say, organizational learning. And again, back if I were the supervisor manager, I'd say, wow, all right, the supervisor manager expectations and actions to promote safety, that's carrying a lot of weight. My staff are telling me they're reporting with this really high mean of 0.78 that matters. So that might provide some positive encouragement to me as the leader of things that I could then communicate with my team, my staff, etc. Similarly, if you're the IP, what would the IP do? The IP can look at these same data and coach their hospital management of this information.
Yeah, I'm interested in like going back to some of the inter-rater reliability and some of the observations that you're talking about, reporting to the managers about what's going good, what's going bad. And we already talked about what actions constitute adherence or non-adherence to standard precautions. But I wanted to clarify of those observations, which were perceived adherence or real adherence, because I want to get an idea if you all got a sense of this at all. I wonder what the perception of how healthcare workers think they do is to the percentage of how they're actually doing with standard precautions.
Fabulous question. And Elaine and I had documented this in the prior pilot work of this study, also published in AJIC, that there was discordance there. And so people are going to say, oh, yeah, no, I do everything right all the time. My frequency, right? I'm rating that. I always do this. I always do that. But that other, go check out that Nikki over there. Nikki never does anything right.
or maybe I do it 90%.
Anything right.
Nowadays,
right, or maybe 90%.
Yeah, most people have wised up, so they don't say they always do it. They say, 90% of the time I do it, but everybody else, doesn't do it half of the time. So,
it's funny because every time we go onto the floor, somebody has something to tell me about, like, you know who it is that's really not doing their hand hygiene. It's the physicians. Yes. Everybody always says that.
Mm-hmm. Yeah, I've experienced that so often in, boots on the ground collecting IP data, and I would have, some key informants that would do the same thing, Nikki. They'd say, "Oh yeah, no, watch out for that anesthesiologist, or look at this person, or look at this person." I say, "But wait a minute, you're chewing gum and putting on your lipstick and grabbing your phone while you're also, touching a patient's Foley catheter. What's going on here, right?"
Your nails are 2 inches long, and your nails are 2 inches long and 4 inches thick.
So that does, and so there's discordance, not surprisingly, between the observational data, and I think what you're getting at, perhaps, is, and a point of heated discussion for decades in infection prevention communities, APIC, SHEA, et cetera. What's better, right? What's cost effective? What's better? What do we do? Do we use this little video monitoring device? Do we use glow germ? Do we use some sort of infrared monitoring? Do we use observers? And I think there's value in both types of data. And what I learned from working with the liaisons and training them in some other work on site, but also heard from the liaisons in this study, is they're learning. They're learning a lot. So if you slow them down, right? So we're saying, hey, collect these data from the vantage of, you're a fly on the wall. You're watching people come in and out of a room and marking what they do. And so first of all, as many providers would want to do, they want to intervene right away. And for the point of research, we weren't intervening in this. But when you have a nurse educator slow down, a manager slow down, a clinical nurse, an IP, and they watch this, it opens their eyes to how many things what's going on. And so in one example, not funny, but a real world example, was what I call the Uniglover. And the Uniglover was such a well-intended nursing assistant who was trying to assist a patient off a bedpan, and felt to do so, he only needed to glove his left hand, right? And so the left hand he would use, and the clean hand he would use to pull down the sheet, right, for the patient contact. And then with the gloved hand, he would go and then empty out the bedpan. And so the question became, well, Amanda, are we going to mark that as adherent or not adherent? Is that a yes or a no? Were they gloved or not? And, and so that comes back to that whole inter-rater and coming up with those key definitions. As we all know, in the realm of IP, these definitions, clinical or surveillance definitions, are paramount importance.
They are, because if you talk to that guy, he has thought through a process. He's thought through why he's doing what he's doing.
Right.
It may not be right, but
right. Yeah.
Right. And so that's really, so back also to, I think Jesse had asked before too, what are these other things that may predict this, right? So safety climate's one of it, but what are those decision-making criteria? What is it about clinical decision-making? What goes through your mind about risk mitigation, risk exposure? And I think importantly with HAIs, as opposed to thinking about rapid responses and performing CPR or doing some of these more life-saving type procedures people would think about, is that it's so distal, it's so latent. You don't see it until so much further out that you don't get that temporal feedback, right? That you've done something right or wrong, or maybe the glove worked, or maybe it didn't. You don't know. You don't know. When you come back in 5 days to your shift and that patient is now isolated with MRSA, do you attribute that to or C. diff? Do you attribute that to the wearing the one glove or not washing your hands? Likely not. Likely not. So getting at some of those decision-making thought processes, concepts of psychological safety, being able to speak up and speak out, right? What they call your situational cognition or your street smarts. I think that's a great avenue, one which we are currently also beginning to pursue within our program of research.
Great. Thank you so much. That was such a comprehensive explanation, even though, like you said, it is the $1 million question. So after exclusions, the article says there were 5,285 standard precaution observations. 452 surveys were collected from across 43 units in 13 hospitals from 6 different states. That's amazing. And as you mentioned, aim 1 was to observe the association between the patient safety climate and adherence to standard precautions. Can you tell us a little bit about what your findings were for aim 1?
Yeah. So when you approach research, again, you want to sort of parse this down into little bite-sized chunks. They each become a specific and different aim. And so the first was like, I couldn't really examine sort of the aim 3 if I didn't know anything about aim 1 and aim 2. And that's where, this was a really data-rich study but it's also challenging to tease out what we saw. And so to simplify this, again, we were not surprised that your perceptions of how you conduct standard precautions is related to the environment, how you report the environment being conducive to the standard precautions. Nor were we surprised that was also related to your perceptions of your overarching positive thoughts about having a good safety climate where you work. But when we looked at on those same units, right? So we're not observing that nurse who's responding. We're collecting enough data that, again, because your climate becomes representative of all actors on that space. And so it might be that, indeed, maybe all of the nurses really were 100% in, but we didn't observe those specific nurses. We have observed all these other numbers of folks on that unit, again, borrowing from the World Health Organization guidelines of aiming at that point for 100 to 200 per unit. And so we did not see an observation between observed and reported, which we expected, nor did we see a relationship between safety climate and what we observed on that unit. And that's why when we look at aim 3, and before we do that, to your point, Jesse, again, power is, although this was commendable that we were able to collect so much data from so many sites, our initial aim was to collect 87 different units. And we would have liked to have more data. We had a number of IPs across the country that engaged in many discussions over a year to join the study, so willing to do so, but they were then unable to. So while we did have a lot of data, there's always an issue of what A, you didn't measure, and B, what occurred at such a low level that it didn't show anything. So, Elaine, I think you wanted to add something to that, Elaine?
It was me that had that.
But I actually did want to say something a little bit more about the discrepancy between what people say they do and what they actually do. I don't think it's only because they perceive a difference, but I'm thinking there's a very strong relationship between the culture, the organizational climate, and the team culture, and somebody feeling like nobody's got their back. if there's not a team culture, you've got a blaming culture. And so if something goes wrong on the unit, if there are HAIs, if there's lack of compliance with behaviors, or, if the hand hygiene observations say that it wasn't great, then people are afraid to say that they didn't do it because they are going to be on a plank with people, sticking them in the back so that they jump into the ocean. So there's a lot of this blaming culture and a lot of fear that if I really say what I do, even if I have a good reason for doing it, nobody's got my back. My peers are not going to help. And so I really think that this whole idea of the relationship between organizational climate, behavior, perceptions, and what people say are so related that some of this is not even conscious. But
I want to talk.
Yeah.
And go ahead, Jesse, because I'm going to dig more into that.
No, I was just going to say this gets into a lot of conversations that, our organization and a lot of other organizations are having now around just culture and psychological safety within teams, and how, all of these things intertwine to, produce the best outcomes for our patients. But if we don't have those sort of from leadership down and really sort of, it's the word I'm looking for, like really built into our organization, then we don't have the tools necessary to make sure that we are, producing the best outcomes for our patients. And so I can totally see how somebody might say, yeah, I do it 100% of the time, because they don't, even if they're doing it differently. And they, like we said with this person before, where maybe they had worked out the process and thought it was the best idea, they may not even feel comfortable sharing that new process with their team or their leaders for fear of, some sort of poor outcome for them.
Sure. Yeah. And we've had a rough couple of years with culture. We're at the heels of a pandemic, and, the CDC reported in 2022 that nearly 30,000 U.S. patients died from commonly encountered antimicrobial resistant infections during the first year of the pandemic. Around 40 of those patients were hospitalized when they got it. So that led me to thinking, your data was collected between January 2017 and October of 2018. And you excluded from those results the nurses who hadn't worked, a minimum time requirement to be considered part of the unit climate, right? So, I feel like we've talked about an increase in travel nurses post survey collection, especially due to COVID, which would significantly impact a hospital's unit or a hospital's culture of safety. Those units, I think that might lead to a lot of suffering for that culture of climate, or that climate of safety, that culture of safety. So do you all have any input on, if you went and collected data now, with that new change, what would it be like?
So that is a terrific question. One which I'm excited but not excited to share sort of what we're finding and what we're doing with some current research. So first, with regards to safety climate, right, so we followed some of the guidance and the definitions which would indicate that, to be a cohesive team, to have a climate, you need to hang together for a certain amount of time, right? What makes the team the team? And so this was collected, as you pointed out, pre-COVID. And post-COVID, we've been working on collecting some additional data in another study, which is looking at an intervention arm of this. And I will tell you, across these sites, both documented in the literature, but also across these sites and anecdotally, turnover, burnout, the use of travel, float, and other nurses that were pulled early on off of retirement, where they did. You may not have worked for 10 years, but you went to your state board, said, you're in, we need you, go back to the hospital, we need you right now. All of these, right? These were all temporary, and they weren't part of the team, and they would bring with them the way we do things here. Wherever the here was, they would bring it to the new there, right? So they would bring the way they've done things before and elsewhere, and they would have to quickly learn what the policies and procedures are of the new here. but they may have had other, I'll just say, solutions, aka Band-Aids of how to fix things when things aren't quite right, how they might, in another site or setting, attach 4 to 5 different extension tubings to the patient's IV because they couldn't go into the room because of COVID, right? And how do they monitor that from the hallway, and
Right.
who changes it, and all of those things. So I think what we've seen is that climate is different. There's a lot of burnout. I know with, in current work, not just my work, but in the world of research, study subject recruitment can be an issue. I think IPs, as we've read in AGIC and other places as well, great qualitative work has been done to inform us what have IPs gone through, how did they make it to the 3-year top of the curve, and where are they going now? Are they leaving their profession? Are they then taking away all of their institutional memory and their cornerstone of the safety climate of their organization? Similarly with nurses, we're seeing all of that. So certainly, without having sort of that idea of longevity in place or consistency of shift, and even if you did, though, to your point, Nikki, even if you did, what we've all experienced is these ebbs and flows, right? The waxing and waning of this variant versus that variant. So today I might need to gown and goggle per my hospital policy on every patient all day, every time. And tomorrow I may not, right? So what I need to do, I have to constantly adapt to the changes of how I do what it is I'm supposed to do, and do that in context of new people whose face I've never seen and whose hand I've never shook and who I've never worked with, and I don't know if they're a good nurse or not.
Right.
Yeah, let me add that the CDC has already confirmed that HAI rates increased during COVID during the last 2 years by as much as 25%, which is astounding because, and it's counterintuitive because you think that when they're supposed to be more careful with COVID, that it would reduce, other problems, but in fact it has not. And if you think about the sort of 3 elements that really make a good team culture, that is a cause worth fighting for, that people care. And I think that the staff still have the feeling that they have a cause worth fighting for, and that is reducing, making patients' quality of life better and reducing problems for patients. It's some intellectual diversity, which I think we have, but the psychological safety, those 3 elements of the thing that makes a good culture is missing. People are feeling unsupported, not only by each other, but also by administration. And because of that, I think, people feel nursing and other healthcare providers are willing to work hard, but not when they feel like they're the only ones and they're in isolation. So it all fits together.
Yeah, I think that makes a lot of sense. I think, with all of the burnout, that a lot of folks are probably just thinking, I can only do what I can do, and I have to take care of myself. And so that depletes that team feeling and the sense of support as well. And so you just mentioned HAIs, and that was actually, part of the aim too, which was really interesting to me, was the relationship between adherence to standard precautions and HAIs, or healthcare worker exposures. And so per the research, it sounds like there were no significant correlations found. Were you surprised by this at all?
So that's a terrific question. And so I think we really were, and because that was between reported adherence in aggregate, as well as overall observed adherence. To your earlier question, Jesse, when we began this conversation, you commented on how much data was in this paper and how dense it is. And so what I could share with you is that when I looked at some specific item levels, which is beyond the scope of this paper, but I looked specifically at hand hygiene, non-punitive environment and hand hygiene, or teamwork and PPE usage. There were some associations identified there. But for the purposes of this paper, I want to look at the big picture and the overall bucket of reported adherence, meaning all of those 12 items that we spoke about earlier for that part of that safety survey, and aggregate of all the observations, and examine that with relationship to the healthcare worker overall exposures and overall HAI events at the unit level. Again, this is a unit level analyses. And so that's why I concluded that, well, I didn't conclude, the data showed that there was no significant association. And I was frustrated, to your point. I remember coming into Elaine's office several times and saying, oh my gosh, I can't believe I'm not finding anything. Why is there nothing there? It's breaking my hypothesis. and that's the nature of research, right? Knowledge is knowledge, and knowledge gained of positive findings that might support what you hypothesize, as well as new knowledge which indicates that something may not exist, are they're both important, and it's an ethical responsibility to share both with the other practitioners, scientists, et cetera, who are out there. So I hope I answered your question.
Yeah, and I think it sort of speaks to the fact that how research, to your point, how important the research is, because, we have these assumptions. We think we know what's going on, or, what's correlated with what, and that actually may not be the case. So I think this is a great illustration of that.
Yeah, so that gets back to, this is one of my driving questions, which I would, be pulling my hair out and saying, but we don't know. When you're the clinician, the nursing aide, the nurse, the physician, whoever, and you're struggling to do the right thing the right way all of the time, and you say, how am I supposed to do that? And I would often say, Elaine, how much time would this take to do the right thing the right way for the right, for each patient? If I've got a patient load of 6 to 8 as a bedside nurse, or even an ICU, but there's more touch points, so there's more points of contact, right? To do the right thing. So I say, well, we put forward these wonderful recommendations in an ideal world, and the CDC has long held on to these standard precautions in an ideal world. But when we actually measure them, do they work? And this is one of the first studies which might suggest that there's more going on, and more, research and data needs to be collected. I think particularly as these recommendations put so much onus on the provider rather than the organization. Of course, we do want personal and professional responsibility for one's own action, which we include in the discussion, but that also puts a lot of pressure on the organization to set the stage for all of the actors to play their parts correctly.
Yeah.
Yeah, and the last aim was observation of the relationship between the patient safety climate, observed adherence to standard precautions, and HAIs and healthcare worker exposures. So can you break down some of the results in this aim? I know a lot of it sounds like what we've talked about.
Yeah, no, that's a terrific question. And so, this aim is different, right? And so one way we could have approached this was to say, hey, we didn't see anything between standard precaution adherence and HAIs or healthcare worker exposures. So let's just end that there. But our aim of this overarching study was to examine this group, right? This cluster of conditions and factors such as HAI adherence, such as your aggregate safety culture, and also some potential organizational or structural factors that we've pointed out before. And when you put all of them into a multivariable regression model, sometimes you may see the combination of factors is statistically significant. And it'll show you which individual level factors may have contributed and which ones didn't. And in these overarching models, the omnibus models, showed that the combination of those factors did significantly relate to, or some variance, as we would call it, in these important outcomes of CLABSI, of these important outcomes of MRSA, right? Of CAUTI, not CLABSI, but CAUTI, MRSA, as well as nurse mucocutaneous exposures, as well as all needle sticks and sharps injuries, and all provider mucocutaneous exposures. So that's where it gets a bit more difficult, Nikki, to the point of your question, is to say, hey, what's going on here? And so I think a key takeaway of this is, hey, this cluster of factors, some which are occurring by self-report, and in this case, these are all observed adherence, but safety climate is self-report, and some that we're observing, and their magnet status or their nurse staffing are telling us, yeah, this does relate to these important outcomes. And then you've got to tease it apart more. And so, again, we don't want to overstate our findings and what the data shows. And I do appreciate your question here, because I think there are obviously, limitations and future direction that could be taken with work such as this.
Let me just add one comment about Amanda, your information that safety climate is self-reported. In fact, there's no other way to find out what safety climate is, because by definition, safety climate is how people feel in their environment. So you can't really directly measure the culture of a place. All you can measure is people's feeling about what it's like, and that's really what matters. So it's not a negative that it's self-report. It's essential. The only way you can evaluate people's feelings and attitudes is by asking them. You can look at some side effects, like if they're looking mad or sad or, behaving in a certain way. But really, it's the right thing to do. So what really matters for safety climate is how people are feeling. And that's very clear now that people are not feeling good.
Yeah, for sure. So what were some of the conclusions that were made from observations based on the roles of the healthcare worker? So we did talk a little bit about nursing teams and maybe pointing fingers to providers and things like that. But what kind of conclusions can we make about the observations specifically around the specific roles?
So terrific question. One which, again, it's important where this is not a pointing of fingers. This is not a I'm better than you because I work in this role or that role, but rather this is what we're seeing. And in practice, many of us might have experienced that in the past decade or so, I think schools are doing a better job of training both nursing students and medical students, et cetera. And so in practice, you may see the early nurse clinicians or physician residents, they come in with great adherence, but it's over time and overexposure to those that they consider senior in literature would also support this, that their behaviors begin to decay. And so while we see there's different adherence by role and by category, and there's opportunities to strengthen some of those, what surprised me is that some things that a specific role might do more often, they seem to have lower adherence to. And so do they have this, what I think about as a role-based normalization of deviance. Like, hey, I change bedpans all the time. Hey, I use linen handling all the time. Therefore, I don't need to do it sort of as much, right? So when you think about that, your nursing aides are probably going to be handling linen much more frequently than your physicians, and we had no data there, but as an example, or your nurses. And so why, if that's their highest risk of usage, are they at that low percent, 66% adherence, right? And the nurses, when we look at that and their use of PPE, they were very adherent, 86% adherent to that. They were much more adherent than I would have expected to the use of PPE than they were to hand hygiene, right? Hand hygiene is lower than all of these categories across the board, as we can see in the data. But because they handle sharps more often, you would think that they would be more adherent to that. But they, again, just have this, I'm so familiar and confident and comfortable doing this. I do it all the time. Therefore, I don't need to be as safe doing it.
Mm-hmm.
Yeah, and it's interesting when we talk about, you've got techs, physicians, nurses, lab, EVS, all these different workers doing all these different things. And it's fascinating what you can see once that culture of safety is established. So I know there's a story in one of our hospitals about an EVS worker who alerted a physician that he was in a patient's room without the proper PPE on. And in some hospitals, that would be completely unheard of. And even more so, the physician ended up thanking him. So, that's the culture that we all dream of.
Yeah,
absolutely.
There is some evidence in the literature that there's an inverse relationship between education and adherence to infection prevention and control practices. So people who know more feel that they can decide and do a fast mental risk benefit ratio about when you need to do something or when you can either get away without doing it or there won't be any adverse events. So in general, in nursing homes, for example, often the CNAs are the most adherent. So this is a little bit surprising that they're not so much, but I think also people learn that if there's no repercussions, if they never see any outcomes from doing the right thing, they'll get a little bit tired. It's kind of like I used to cook sometimes with the Julia Child Joy of Cooking book, right? Which is huge recipes that take half your day. But over the years, I've learned to, quote, cheat a little bit because I can do something a lot faster and it still tastes just fine. So I think that's
True.
the same thing that's happening in healthcare.
That's a really funny example to use. I like that.
Well, I love it because I remember sharing with Elaine, I'm all about what I call the Betty Crocker basics. So I'm not even a Julia Childs level cook, but I call standard precautions.
Me neither anymore.
The Betty Crocker basics, right? So if these are just the basics that we're asking, right? These are standard precautions. We're not talking about caviar here. We're not talking about the cardiac tamponade that we're saving and the life-saving CPR. We're talking standard precautions. So how can we get the other things right on that hierarchy of behaviors if we can't get this basic fundamental strata down pat?
Yeah, so true. So based on your findings, can we say that the units that had the strongest safety climate, greater adherence to standard precautions, and an overall optimal working environment, so like the ideal staffing, do we think that given all of those things that would contribute to a lower HAI rate and lower healthcare worker exposures?
Yes. Yeah, I think that's precisely what these multivariable models are showing us, that combination of factors indicates precisely what you just articulated, Jesse. Yeah.
Well, that's easy, right? Then we'll just do that.
Yeah. Yeah. Just that. Just worry about your nurse staffing.
Snap your fingers.
Snap your fingers.
Well,
I love that story that you shared, Nikki, with the feedback to that physician. And you're right. That's sort of the ideal climate and culture and what you really want to have happen there, right? Yeah. And so what's the weight of each one of these things, whether it's that behavior, whether it's that the magnet, what's the relative merit of all of these? And that's for the local site. So the site that you mentioned may not need to focus so much on safety climate, but may need to focus more on, nurse staffing or something else, right? And so I think, again, it's these data paint a picture, and at the local site, you really have to fill in the numbers, right? The paint by numbers, figure out what works for you, and get your own local data and build it off of a model such as this. Is my thought.
Well, let me ask one more. I just have one more question because it goes along with this. The paper mentions magnet status and how that might contribute to the characteristics. So tell us how.
So the way that I see that is magnet status, and that is a designation which hospitals and healthcare facilities beyond hospitals actually can apply for that designation. It's a status that's honorific, that's earned, that indicates literature for years that hospitals with that designation have better reports of nurse and patient outcomes. And that magnet status has both associated empirical indicators such as the numbers of falls, decubiti, HAIs, et cetera. Also, they have nursing practice environment. And the nursing practice environment could be quite similar to some of those constructs that the Safety Climate Survey picks up. And so we wanted to check to make sure, if there was any collinearity there. But it could be a proxy measure for a better nursing practice environment, that magnet status, right? Because that indicates that those hospitals have a entrenched, right? You don't snap your fingers and get that overnight, but you have a culture, a longstanding culture across your organization, which is different from the climate, which is specific to the unit perceptions, right? So the magnet's looking at your overall hospital safety.
Yeah.
Mm-hmm.
Cool. So, just to close us out for today, thank you so much for joining us and talking all about your research. This is amazing, and again, so much data to look at and go through and interpret and digest. But out of all of this, if there were a couple of takeaways for the listeners, what would they be?
That is a terrific, wow.
There's a lot. Yeah.
There's a lot. First, one key takeaway, I'm putting my IP practitioner hat on, is get involved in research. This project would not have been possible without the participation of IPs who are engaged and interested in research. You can add to this literature. You don't need to be an Amanda Hessels. You don't need to be an Elaine Larson. You need to become involved with research. As we know, our organization, APIC, so strongly encourages us to do so. I think more than beyond that, what you could do is you could take some of these tools, some of this information, and begin to think about how you could translate that in your local setting. So how do you translate that at the point of care? Do you employ some cross-cutting surveillance methodology to capture the risks of your patient and occupational health and safety at your site? Are you doing that yet? And if you have those local data, you could then deliver some really targeted interventions. So I think one thing is one of the outcomes of this is to really empower the IPs with information they can apply, as well as enthusiasm for research. The data, and a key and sort of high level, is that patient safety climate is correlated with higher levels of self-report and observed precautions. Get a good culture, get good behaviors, right? That's the key, simple way of looking at that. Second is that we still have an issue with standard precaution behaviors as measured by observation. This is the largest such set of data which indicates that. Although we're up to 64% in here, that's better than years ago. That's still a coin toss that your family, friend, loved one, whoever is going to have your provider do the right thing, the right time, every time. And third, we're able to show that some, specific combination of factors are related to lower rates of a sizable variance in MRSA, CAUTI, healthcare worker splashes, exposures, and needle stick injuries, anywhere from 23 to 43%. That is huge. And so those would be my three. Okay,
I have
takeaways.
Two. So this is Elaine. I have two more. First of all, to confirm that the solutions to this problem of reducing HAIs ultimately are long-term. You cannot have a quick fix. And therefore, IPs must have the communication skills to understand that what I hear from IPs frequently is, well, my boss is telling me to do this, next week. They need to be able to have the information to communicate with their bosses, with the administration, with the C-suite, that this is a long-term issue that involves the culture of the place. And it's not something that can be solved right away. And they need to the IP needs to own the ability and the willingness to communicate that.
Absolutely. I totally agree with that. And from what I've heard referenced is that to fix culture, it takes, 2 to 5 years, depending on where you're currently at.
Mm-hmm. Mm-hmm.
Yeah.
Yeah, there is a lot of information in here, and it is pretty fascinating because we are going to start digging into cultures of safety and seeing how that affects our patient outcomes. So, ladies, I can't thank you enough for being on here.
AGIC Science into Practice is created by the Association for Professionals in Infection Control and Epidemiology with input from the APIC Research Committee and Pat Stone and Jean Brandt at AGIC, and APIC staff Shanina Knighton, Chris Ruiz, Bobby Gulshan, Christine Miller, Kaylee Deaton, and Kelly Lynn Russell. We work in partnership with Human Factor and audio tech Blake Alton and the field of infection prevention and control. Go to our website at agicscienceintopractice.org. That's AJIC scienceintopractice.org.